open away from you. There's an arrow that's saying away from you. And then you put it down. These two are still sterile, have put aside for the time being, and you go from
Those are gowns.
From one end, all the way at the back end, this end, okay? To this end. Let's say, make believe I'm sterile. I have this gown on, okay? So my nurse will give me the rest of the gowns. Again, away, do not touch anything, drop. Away, do not touch anything, drop. We're gonna make believe this is sterile. It's gonna be open the same way. Away, do not touch anything. The nurse will take it, or you can just drop it on the table. All right, so everything here is sterile. Once that's happened, you fix your...
Can you take the time to show what's in the pack?
Sure.
This is a good time to say, like, this is what's in. Maybe not like...
So the pack has
usable, but...
gowns. So all together you have 4 gowns. You have towels. The towels is to drape the patient, and I'll show you how. And then you have your laps and your Ratex. Your how do you call it? Asepto, exactly. And then you just put your saline here. These are just drapes, and I'm gonna show you how to do it. What I do, if I have the time, if it's not a crashing hot, I tend to do this. This is old school. I normally have at least 4 to 6 towels folded, like so. And what I do, this is what you do with it. You go around the patient from the ear down, as wide as you can. Again. Try not to touch the patient. Remember, I'm still sterile. I have a gown, make believe gown on. And as quick as you could do this, or if the other doctor's there, you could give him and he could help you out. This I don't even open. I just leave it like that and cover the couch.
I'm sorry, no, I just wanted to add, just so everybody knows, this is after we prep the patient.
After you prep, this is all prepped out with it comes with the program. You could the scrub person just pass it on to the circulator, and she'll prep from the ear all the way down to here. Especially rub here if you need a second. Some people are big. Get another one. Rub the groins very well. Okay.
In that same drawer, I'm sorry to step on you, but I'll just
big
add
tape.
to. Well, there's the tape, but I just want to say, like, sometimes for us, this takes some time. So the first thing they're going to want preps. There's also preps in that same drawer.
Extra preps.
Yeah, so when you look in there, we'll talk about what the contents of that are.
If you look here, yeah, there is here too.
But also in the
there's an
same
extra drawer.
Exactly.
Is that right?
In case your doc is sterile already and you want to start prepping.
So all of these also need to be open, one of each, okay, on the field sterilely. If it's not a crazy rush, you should be able to flush all of these with your saline, all right? So I'm trying to talk with 2 ways. I hope I'm not confusing you guys. So meanwhile, back to this, you drape like so, and you open it.
Why are the needles and the dilators and stuff not part of it?
No, they're not part of it.
Different manufacturer.
Yeah.
They come in like different things.
You open like so.
It'd be nice.
Try to keep it part of that earlobe out when you're prepping, okay? Then you take this long, heavy drape, and I'm not gonna undo it all the way.
Please, yeah.
You see the bar? The bar is what goes to the neck, okay? The bar goes to the neck, and then once you open, you pull all these tabs and line the patient out. I don't wanna unfold it, okay? Yeah, line the patient out. Line the patient out. Make sure the feet is covered. That's the reason why. The reason we use this large drape, because it covers all the way to the bed, and the guide wires are long, so we're not contaminating the guide wires. That's the whole reason for that huge drape. Okay, that being said, meanwhile, I'm going back to the scrub person. What I would be doing right now is making sure I have the doctor's gown, the doctor's glove. I have this set. What I would be doing is getting all my pump clamps ready to go. My scissors. I would have them in a nice, neat fashion quickly. and just put it where I could just reach, look and reach, okay? Now, the first thing the surgeon's gonna want is what? Once he's draped, what he's gonna ask for? Ultrasound, exactly. So,
Yeah, sleep. Hey, look at all this side of it.
so this is here, this is sterile now, guys. So the first thing I'm gonna hand out to anyone, my circulator, is my ultrasound. Once you have the ultrasound, it comes up, the surgeon, what do you need next?
Our ultrasound sleeve looks differently, by the way, than that. That's the red one with the red label.
We don't want this one.
Yeah, we actually have one. I'll just show you what it looks like. I think it's,
But the one that we have downstairs is longer.
yeah, but we have it in another drawer. They were like all over here. Sorry, take this strap and you can see me while I'll find it.
But it should honestly be with all the kits in the drawer.
It is in the
It's
drawer.
because
We
the
just
plane
switch
is
it.
not in where it needs to be. It's normally with everything.
But it looks like that.
This is longer. The reason we don't use this is because it's short and you're contaminated, so you bring the cord up. This one is longer, so you use that. So you have that on the field. What do you need next to give the surgeon? Make believe whoever's here, I'm not here. What do you need to give the surgeon next?
Something to stick.
Stick, thank you. So what's it stick with? Remember, sometimes there's two surgeons, right?
Right, so there's-
Sometimes there may be one and sometimes there's two.
There's always, so two different insertion kits, okay? Short insertion
The
kit,
swans,
yes, short insertion kit for short cannula, so that's the
Arterial.
arterial cannula.
right,
Long insertion,
Venus.
venous.
It's the
Okay?
Avalon, it's
Right,
Venus.
so you can always remember that, short cannula, long cannula. And that way there won't be any confusion, regardless of whether we're doing ECPR, so VA ECMO, or if we're doing bicable cannulation, VD, it's always the same set of cannulas and always the same insertion kit. Short for the, in VD, we're sticking the short one in neck and the long one in the groin. Now, I would keep everything on sterile because sometimes if patients are really heavy, we may have to use the Avalon dilators for the arterial as well, okay? So we may have to flip back
Never
and
throw
forth.
anything out.
Yeah.
Don't throw
And try to
anything out.
keep everything intact. So one of the things I think Dominique will show you is the wire, how we handle the wire. Because if you lose the wire and it loses sterility, then they have to go out and find another one. That gets to be a real painful process. So the key to us to being fast is not to be fast, just to be efficient, okay, and avoid making mistakes. That's how things go fast. We don't have to have a frenzy of activity. Every ECPR should be run very calmly, smoothly. No one has to be doing this, because whatever, in order to make it fast, it is just us being methodical and step by step, and then avoiding any mistakes. Okay.
So if both surgeons, both, attending or Dr. Wong is doing it, there's 2 needles, one for each. One of your main job is whoever hits the arterial would do what? Squirt. So if the arterial is squirting, which one, we just spoke about it, which one would you give? Which one? Blue, right, Monty, do me a favor. So it's pumping blood, so Monty, hopefully that'll be ready already.
Can we open it?
Yeah, it's expired,
Yeah.
it's expired.
Each kit comes with its own needle. You can put it. So we're
So,
starting with this.
no, I need the guide wire first, guide wire first. So he'll put the guide, I'm not gonna pull it out, he'll put the guide wire in, pull this pink needle out, he's holding on to that. So we have to guide this out for him, okay? And then she's gonna put the first small one and go up to the size before the size of the cannula. So let's say the cannula was what,
Today's a 22.
sorry?
Today, oh, I'm sorry, arterial, we got
Yeah.
17.
So let's say it's a 17, so you don't go any higher than a 16 or 14. And what would be the high? So it's a
16,
17, so
and
we go
instead
up
of
to 16. You don't go at the size of the cannula. You go one size below the cannula. Okay? So you'll just keep going up, take this out, keep going up, take it out, keep
16.
going up,
And
and
always communicate.
communicate. This, hey, Dr. Wong, this is a 16. So the next one would be what? If we stop here, when we pull this out, what's gonna be a cannula's in. What are you gonna need once the cannula goes in? Who? Clamps, very good. Talk to me. Yeah, I want you guys to talk to me. So he's gonna pull the guide wire out, and once he pulls that guide wire out, it's gonna shoot out blood. So you clamp, boom, right? Okay, so that's done. All right. The same thing for the venous. It's the same exact thing for the venous. The needle, the guide wire, the dilators, the cannula, boom, clamp. One of the important things now, the perfusionist is gonna give you the tubing. The tubing, one is red, one is blue. It is very important because I've seen where we mix it, and that's one of the reasons why Dr. Wong wants us on the arterial to put 2 clamps on it once you divide it. Okay? So once you confirm this is arterial, you put 2 pump clamp and then cut it. And then the venous will only have 1 pump clamp on it. So when you're giving it to him, for arterial, should have 2 pump clamps on it.
You're just doing that just to
Okay.
distinguish for
Right, so we do the same
additional.
thing for VVs. All the return should always have 2 clamps on, not
I
because
got
you
you.
need it, but because it's just
It's just
visually
visual.
differentiated.
That's
There's
all
no
it
confusion,
is.
Because once you cut it, portions of the tape that's marked red and blue may not be visible.
Right.
So, again, that's just, so small things like this help to make it faster, because if you connect it and you realize you're going the wrong direction, then you have to come off, disconnect.
Yes.
Usually that means
a lot of
recutting the
problem.
tubing. So this is what I mean, it's just not about being fast. It really is just about efficiency of motion to get things done quickly without hurrying.
Correct. So now I'm doing arterial. I make sure arterial has the 2 clamp, because I'm sure you verify that. He's gonna take these 2 pump clamps, right? He's gonna take them off. While he does that, what are we doing? We're squirting not to get air, so for him to connect. We're gonna do the same thing on the other side. When he's ready to connect, you get your saline ready, and try not to do this. You need to go on top. Okay? This is not gonna help him. This is just pushing more air in. On top, and keep squirting as he connects. Once he connects, he says go on. One should be dark, the venous should be dark, the arterial should be like kind of reddish, okay? Once we go on, what are we gonna need to secure it? Sutures. So once he confirmed, hey, it's working, it's the right one, these are the sutures that you gotta load up.
They don't come in the pack, right?
No, they're in the,
That should
they're
be
in there also. You just take this,
What are they?
sutures,
No,
silk,
Zero
silk. Yeah.
Just a whole bunch of
Zero
them.
cells.
He's gonna use that whole pack to
So these
secure
are, so
both of them.
these are pop-ups. So
Right.
we just sort of just pull it and we'll tie it and then we'll cut it after.
Be mindful, there's shops. Be mindful not to just drop them anywhere.
And
There
your kit
is
comes
this
with a
little
needle
thing
holder.
here. Once you start pulling out needles, drop them in here so you don't stick yourself or hurt somebody else with the needle.
The one that
Okay.
you're guiding out with him, you're dropping it.
You could
into
even
this.
drop it in there. Just poke it in there, it should stay in there. Okay? Because I don't want anyone getting hurt with the needles. So we're gonna need all of that to secure it, and basically that's it. We're on backpack. I mean, we're on ECMO.
Same thing.
Same thing.
Okay? All
Are
right,
we
any
counting-
question?
Are we counting
Okay,
the
yes,
needles?
okay.
Just
This is another thing we're having right now with downstairs, we're making a big thing out of it. Number one, I just spent so much money buying pump clamps. That is a huge problem for me. Once everything is calm, we're pulling the drapes, please make sure we get the 6 pump clamp back into the tray. Okay, these are costly. For some reason, we're losing them nonstop, and I have to explain to administration why I just bought 80 of them this week. Yeah, and it's not fun. Please, and I asked Linda, at the end of the day, please make sure there's a paper that comes in the sterile thing. The quantity should be the same thing. I think it says like 14 or I don't know, is it 8, 13?
pieces.
13 pieces at the end before you bring it downstairs to be re-washed. 13 pieces has to be there, please. When you take it downstairs for them to reprocess it, tell them you need it stat as soon as possible. Get the person's name before the end of your shift. Make sure it came back up.
So
Okay.
the thing about this is that do not keep these for our bedside non-sterile clamp uses. Then we have those.
Yes, they have right.
We can, those are a separate budget for these things, and we should just, so make sure that we use our bedside for our bedside use. These sterile ones do not
Mix them.
commingle them
Right,
into
do not mix
the
them.
The bedside
non-sterile.
one has the purple. It used to be-
They're all mixed up right now because of that. They all mix up. So like I said, I just bought a bunch. All we have to do at the end of the case, make sure whatever quantity we started with is what we end up with. Because already, I think 2 was missing from one of your trays you guys brought down. And the first thing they said, well, you didn't send it down. We processed what you gave us. So they're blaming you guys for losing these things. So please, sign your name, initial, that you checked it, it was counted, and you send it back down. And it has to be processed ASAP. Okay, any question?
So we mentioned about saving everything, like not getting rid of the guide wire.
Right.
How do we make sure that we manage that?
One of the things my staff has started to do, which is good, okay, if you have the chance, because I know things could get crazy, because sometimes I just wrap it and put a towel. Some people are not as quick as some of my other scrub people that they know. What they try to do is put it back in the house.
As you're taking it out?
As you're taking it out, take the house and just push it back in there.
Okay.
You understand what I'm saying?
Yeah,
So it's
okay.
not all over the place.
And then the dilators, how do we manage the dilators?
The
in case
dilators,
we-
keep them separate, the blue with the
Okay.
blue, the peach with the peach,
Okay,
okay?
so
along with
Sometimes
the-
he may
along the line.
ask just to use just this to get into the arterial. Or the other one, the bigger one, just to get to the venous because it's much narrower.
Right, okay.
Okay, so the short blue ones have a little pouch of their own, so
Okay.
just
Put them back in
Put
the
them
pouch.
back
in
in,
the
yeah.
pouch. So
Okay.
when you dilate, so again,
Just go right
same
back.
thing, when you first dilator goes in, dilator comes out, put it in a pouch. Next dilator goes in, comes out, goes in the pouch. That way everything stays minimally messy.
One of the things I
However-
forgot to tell you guys with the Avulon, this one goes first before we start dilating up. We tend to forget this one, okay? There's the blue first and Avulon, okay, before we start with that. Even we
That's
forget
nice.
sometimes, my staff. This starts first, okay? And then we start dilating up.
So next question, do you have one person helping who's ever doing the arterial access and one person assisting the venous?
Not necessarily.
Because that's where I can think it could get crazy,
It
because
could
they're
get
throwing
crazy.
dilators at you and you're trying to.
Ideally, but not necessarily.
Yes.
Okay.
There's no throwing, you just have to really pay attention. Your focus when you're there, scrub, is just on those 2 physicians. That is it. You're not paying attention to anything else going on in the room.
Right.
That is your only
But it's
job.
even with 2 physicians, it's a lot.
So
It's a lot.
usually what you should do, if there are 2 of us working simultaneously, you should work on helping the intensivists first, okay? Because with all due respect to intensivists, I've cannulated a lot more people than they have, just because I think of what I do. So I can almost pretty much do this, figure out how to do this by myself, or I can have somebody help me in a minute, or we can just go on one side first and the other.
Or
Whatever the,
what we've done too, once you give the 2 needles, just separate it like so.
I was just gonna say,
Okay.
our scrub techs.
And just say, this is for arterial, but then again, it depends what they hit first. You gotta visualize what they hit first.
so
You know, when they're
right.
digging in, if you see arterial, you just say, okay, sir, then this is yours, it's already been primed, take care of yourself. Here.
Put the set on the
And then you can
side
help
of
him.
Right, so you
see
so
what I'm saying?
First
Yes.
thing to do is help the intensivist first, and then we'll figure out the rest of the stuff. Again, all we need to get cannula on one side, and we will have time
For the other.
on the other side. So it doesn't, if we have enough people, we can do it in parallel. If we don't have enough people, we can do one side and the other. But once we gain access, the dilation should be fairly straightforward. Well, I should say that, but it's not always so. But the reality is get one side in and we'll get on the other side. And so sometimes we have to help each other too.
But I've
So-
seen it gets crazy, you're doing CPR and everybody's screaming and blah, blah, blah. Like when we were in the ER downstairs, I had another tech, 2 scrub tech, 1 for each person, which helped out a lot. Because then you're getting it in, the patient's really crashing, you wanna get on
The circuit as
ECMO.
fast as
Right, as
possible.
soon as you can, exactly. If you have the chance.
Sorry, I'm a newbie.
No, absolutely.
The only ECPR I've done was down in ER ages ago.
Right.
We're doing compression while we're cannulating.
Right.
We didn't have this whole setup.
How do you do compressions and cannulate at the same time and drape for this patient?
Okay, you, number 1, as you're doing compression, someone sterile needs to be draping, whoever's gonna take over once we prep, needs to be sterile with sterile gloves,
Doing compression.
doing compression.
To
switch
so that
over.
we can prep,
So
and
I'm not
switch.
sterile, okay, come, compression.
someone.
One of my
else
nurses
needs to
is
prep.
prepping around my hand, I'm still doing compression. Now, when I'm ready to release, are you ready?
I'm
Are
ready.
you ready? I move
ready.
away,
Finish,
and then
and then you start
she
compression.
stops.
I'm already.
And then the other person is not draping.
So like, but when they're covered from head to toe, how do you do, is there a hole in the
No.
middle to do compression?
Yeah, this is
It's
open.
before the drape goes down,
Yeah.
ideally. You're doing the switch before the drape goes down.
Okay.
But
But
even-
there's a hole for you to continue to
To
do
go
compression.
around her,
Yeah,
yes,
yeah, yeah.
yes. This drape has a
Chest is
split
exposed.
drape. It's a split drape.
Okay.
It's down
So it
low,
goes
the
like
chest is
this.
still covered.
So the whole chest is
Depends on how
exposed.
we
No,
do it.
no, they're two different,
Chest is open.
No, it's all,
Splits of the head.
yes.
Wow.
This thing is long enough, so sometimes we don't do it because.
I'm not gonna
we're
open it, I'm just gonna open one side. Look, guys.
So that you can't see where you're getting compression?
like, okay, cause you're like totally covered from head to toe, but like, how are you doing compression?
No,
Gigi, look.
So it's open.
It's
It's
open.
It goes
And the
on the
person, and the
side.
person that's doing compression is sterile when you're open.
When we switch, after we prep, okay? The person that is sterile is now doing compression.
Okay.
So not everybody's sterile.
For our drill, our CPR people
It's
get
not,
sterile.
it's not your,
In the beginning.
it's not your scrub person, it's
While
usually,
they're prepping, the sterile person.
and it's usually like RT or somebody, it's not your scrub person that's gonna take
Right.
it. You know, it's
A
somebody
lot
else.
of things are happening all at the same time, and plus, just one little aside, is that, don't forget, we always do a cause for the cause, so the nurse responsible for the patient needs to make sure they put that documentation into the computer. So, and you need to list all the people that are there for the procedure.
After the fact.
Yeah, but there's a lot of things going on simultaneously.
A lot is going on here.
Number
Yes.
one rule is get the patient on.
But yes, we'll continue compress. And even when he's doing it, you guys might still be doing CPR. And once he tells you to stop, stop. And then he'll say go, and you keep going.
So this is the important thing, this is why we have discussed with, for example, ED not to run the code in our intensive arrive. Because the process for when we start ECPR, the goal is to get the patient on quickly, not to continue this CPR. So the priority changes and sometimes they forget. So, they're like compression for 2 minutes until they do the next pulse check, whatever. At that point, that's almost entirely not really pertinent to what we're gonna do. So the goal of us doing ECPR is the E part. The CPR follows the E. So we get them on the E part first, and so that's why our intensivists will run the code, as they'll tell you when to start, when to stop, et cetera, et cetera. The pulse check and all of it, by the time they call us, it's usually pretty much not really an issue for us to do pulse check, whatever it is. Get them on, and once they're on, we can figure out the rest of it. And so, again, when you're down in the scenario, whatever it is, listen to the intensivist, and you only do what he or she is asking you to do, and not anyone else. And again, clear the room from everybody who doesn't need to be there, because these things tend to attract a lot of people, and they just get in the way of us moving all this equipment in the room. We have a fortunate thing about having a lot of space here when we do these things in the
Not in the
ICU.
ER.
But down in the ER, down in the CT scanner, wherever else these things occur, we don't have that kind of room, and we don't have the luxury, even on 7-6 North, right? When we go there and put somebody on, it's a very crowded area, and less people the better. There really doesn't need to be that many people in the room for us to have a successful ECPR. I think if you see this today, you'll be able to understand, we've gone through this, and you'll see the people, so for example, if you're doing CPR and you're not sterile, the next person who replaces you is sterile, then you go get gowns after you come off, and so now you have two sterile people rotating back and forth. Right, so that part of it has to be, and we do this primarily in case we have to go on through the chest.
New at
No, that's
It'll
fine.
make more sense when you see it.
That's fine. So I'm just gonna run down from my head, okay? Just follow me. I mean, I'm kind of crazy, but just follow me. So, ECMO, get the cot, get the ultrasound, make sure you have the access for your drugs, okay? Make sure your defibrillator pads are ready to go. My circulator, start prepping, everything away from the chest, my pad to side, somebody's calling for my 4 units of blood, everybody's getting the cot, the ultrasound, blah, 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 blah. Now, as my scrub person is opening, getting things ready, the other circulator now is making sure everything is away from the patient. What else for that person? She's giving now my scrub person the arterial cannulas, the venous cannulas, the dilators, the ultrasound. So once all of this is in, we're ready to go. Once we are draped, we drape our patient, make sure we have our crotch towel there, we drape our patient from the ear. A little part of the ear needs to show. This drape goes all the way down to the feet. Okay? Once that's ready, the doctors are gonna say, give me the needles, you give them the needle. I mean, no, what goes before the needle? What goes before the needle? The ultrasound. Give them the ultrasound, then give them the needle. We're looking to see who gets the arterial, who gets the venous. Once you realize who gets the arterial, what do they get? Right. Once it's the venous, what do they get? And what happens once you give the long cannula? Which one do you give first? The blue. Okay. Once the wires go in, how far up do you go up to? One below. Oh, one. Oh. Okay. Once the wire pulls out, what do you have ready? Pump clamp. Right. Once the pump clamp is there, both of them are in. What do you have ready? How do you put your bulb syringe? All right. Connect. But before you do that, before we connect, what goes onto the two lines once you divide them?
Two clamps on arterial, one on the.
When you're putting the two on the arterial, what are you looking for? Nope. Besides bubble, that's a very good thing. Bubble. Besides air, which is very important. But what else are you looking for when you the color? Right. So before you put the two clamp, you shake it and say, this is the arterial, and you need to see it's red. Visualize it with the perfusionist that it's red. Then you put the two clamp. Okay? Once that's in, boom, what else do you need? Secure it, right? What do you need to secure it with? Boom. Done. Or an extra.
So there is so just so that you know, for patients who are heavy set and who has large panis, they do have this thing called panis retractor. So it actually works really well. It's
It's a big tape to put on the
right,
belly.
but the nice thing, so we saw this for OB folks, and what it does is it allows us to put a tape. It's basically a clear plastic sheet that's adhesive on it. So you put it on the belly and you pull up, and the upper part also has adhesive tape on their chest. The nice thing about it is you can prep the whole thing over it. So that's something that we can use. So
It's
you don't-
sterilized over the.
Right,
that tape.
the thing itself is actually sterile. I just find it easy, so you can actually, if you're prepped already, you can then apply it down here.
Sterile.
I just find it easier to apply first and prep
Because it
below
holds better.
It holds better
Yeah,
because
because
it's
area
wet
is
and
wet,
so
then it's
forth.
not gonna
Yes,
hold.
Correct.
it holds better.
And plus,
It holds better.
yeah, this is really a very, so again, like I always forget how to use it, it says peel here, whatever it is, but you just stick it on the abdomen and pull out.
Are you keeping that in the cart?
Yeah.
Yes.
And so this actually goes out with us when we go to do, off-site cannulation as well. So that's actually also very helpful. So, so actually, just out of curiosity, is it helpful for us on the next, one of the next times we do this, is for us to do a, simulation of a ECMO cannulation at an outside facility, as far as what's brought there, or what's in the
Outside
bag?
facility or outside room out of the unit?
No, outside facility, like if we're gonna go somewhere, because I
But rather
realize
than
most
the
people.
In my opinion, no, because when we do those are plans.
Okay.
I know my role, Dominique comes, she knows her role, perfusion comes. The difference between outside and here is that we said, we don't have time to wait 30 minutes for them perfusion. So I think training them to like, well, this is in the bag, unless, like we talked about before, the transport team starts taking over other
I
elements of the
think
role, which
they
I don't
will.
think is an
And I think-
ECPR.
Right, so I
That's a
agree,
different
so,
training.
so that's a different training, and maybe we should schedule that for one of our operations meetings, so we can go over that.
Yeah, it's a
in
nice
separate.
big bag.
Because that way you can at least, for those of you, because not everybody goes out to do cannulation off-site, and not everybody's familiar, and I can tell you that over the course of this year, we're gonna wing ourselves off the, OR assistants at bedside, both here, you know, ECPR here, as well as us going to, off-site cannulation. So for us to do that, I think, so,
This drawer, correct, and the top two to get prepped, correct? The other things in here are for open chest. This is a big, this is if I think the chest is, there's one that's tamponade, that's if the chest is closed, you're tamponading, just to give you an idea of what else is here. This one, I believe, was designed if the chest was already opened, if you wanted to like reopen at bedside and suction out. This suture drawer has a lot of different things in it, mostly sutures, has other access needles. If maybe it took you too long to get to these things, and then the physician starts yelling for a needle and a syringe, they're present here, okay? Take your time, and I recommend just going through this stays unlocked in that room over there. Go through and familiarize yourself a little bit when time allows. Yeah, so this down here is all your extra stuff, right? So if you're missing a wire, if a wire's too big, thank you for this over here, like this is a smaller wire that will pass through a quad lumen, so you can use it as an access, exactly. Where your other wires that come in the kit are .035. There's extra dilators down here.
If something falls.
Exactly, which will happen.
And
There's
sometimes the wires could get kinked.
sheets.
The
Yeah.
wires could get kinked as the
Absolutely.
doctors are trying to get in, the patient's calcified, and it comes out, it looks like the wires have
Yeah.
to be tacked. You can't use that again. You have
Yeah.
to get another wire.
So be familiar, these are like your second line drawers, right? I'll mention this one, this extra drawer has a lot of good extra stuff. Sometimes we're there and it's like, I needed a sterile table to put in an art line. So there's drapes, like a little medium table cover that you could cover in. There's art line, actual like 20 gauge arterial lines in there. There's a little pressure thing so we can pick up the transducer and monitor an art line. I won't go through everything, but just know that this card is more than just the drawer we're talking about. I'll leave it at that.
If he's gonna put an Avalon in the neck, what do we need to call for right away?
Fluoroscopy.
Fluoro.
Josh, can you mention what cannula?
So where,
Keep it in mind.
oh,
Yes,
yeah,
cannulas.
where's the
So-
floor, wait a minute, where's the floor, if you need the drape for the floor, where is it?
Yeah, I'm good.
So
I think
you
it's
know.
another drawer as well. That's the extra one, but I believe it's in one of these other
Okay.
ones in addition.
It should only be here.
Is it only there?
Yeah.
Okay.
So really familiarize yourself with that, I'm sorry, go ahead.
Yeah, if you wanna know everything, there's a book that the specialists sign off, but in there, like Mike made this whole nice list after it was changed to this format of everything that should be in those drawers. So it takes you like 20 minutes to just go through and be like, oh, that's where that is. So when you're scrambling for it, it'd be nice to know, oh, there it is. Cannulas. So we pretty much have two different cannula configurations. For the drainage on, let's say, VA, we're talking, because that's where we're gonna really mostly be jumping in emergent situations, potentially. 22 for a drain, 22s are here. Today we're gonna use a 22, it's this big guy over here. It's in a different container, different manufacturers. Oh, I apologize. This is the 22. The drainage that we normally have are 22s, and 23, 25s over here, your bigger option. And then in the back is where we keep most of our return cannulas. They look like this. They're in these boxes, say tandem, and there's 15s and 17s there.
And
So
do
we
me a
have
favor,
17.
don't write on the box, because God forbid we ever have to return them for anything, they will not take anything back if you write on the box.
We have these other arterial cannulas here, but these were ones that we don't normally use. They're bigger ones, they're 19s and 21s. Normally, we've been using the 17s and the 15s.
And I think
Just know
you
that they
wanted to
live
say
back
something
in the
about,
back.
you wanted to condense and make sure that's what we're gonna use.
Hold on. So, you know, when we first started this, we kind of figured that we would just split the patients based on BMI, and that's, or BSA, I'm sorry, so BSA less than 2, we use 15 or 17, and then whatever 22, and then the BSA greater than 2, we use 17, and then 22, 25. By and large, as we gain more experience, I think we could probably almost condense everything down to just 17, 23, 25. So that would be, so, but it's always important when we're in an ECPR situation, ask the intensivist, ask myself, what cannulas we want before we open it, because we may need to make some adjustments. Patients who are heavier set, that for example, use a panaceous retractor, we may never be able to use a 17, because the nice thing about the smaller tandem-like cannula is that they're smaller, and you may have noticed we've been able to do some of these patients without having to put a distal perfusion catheter for their legs. But the problem is it's very floppy, and sometimes you can't push through that way. So that's why we still have the 19 and 21s available. But by and large, you can pretty much be sure the majority of our patients in the ECPR scenario will likely use just a 17 and a 23, 25. Please also keep in mind that, and I think perfusion usually has this, is that when we do ECPR at the end, once the patient's on, we will need a pigtail catheter and a three-way and an adapter, because if we do need to have a distal perfusion catheter, that will allow us to have that done and have a patient have distal perfusion without interrupting the ECMO flow, okay? I think those are all also in there. There are, and the distal perfusion catheters are, these are the wire reinforced 6 French, 7 French catheters, and that's what we always use because it minimizes the risk of kinking. You will not believe the number of times we've gone to the OR at decannulation, and the distal perfusion catheter that we used before that are not reinforced are basically kinked in the soft tissue, so it really isn't doing much of anything. So Dominique has to.
So before I jump to the pigtail, when we open, I forgot to tell you that, when we're opening the venous cannula, you see this connector right here? Well, the black thing is holding it. The black thing you take off, but it's holding a connector for the venous. Do not throw that out. You're gonna need it. So when you're grabbing it, you tend just to pull this out and forget about this. We need that. It needs to be connected to the venous line. Okay?
So that's reduces, because this is a 1/2 inch.
Right, it
and
goes to
then
half
reduces
3/8.
it, right, to a 3/8, because our tubings are 3/8.
Okay?
So we need that adapter to work.
That adapter does not get thrown away. You need it. Otherwise, you're gonna have to open another venous cannula to get it. Alright, so, Dr. Wong, for the perfusion, it could be a 6 French, or you sometimes want to use a reinforced wire, which I
Yeah.
don't see there. But you could use this one too. The C connector. You can't tell it from here, but it's one line with this. Oh, here it goes. This one's reinforced. So whichever one you request. This is, you rather this one though.
Preferably use
The
this.
only reason I think this one's around is because of that MRI. Remember, we had to do an MRI on somebody, we had to exchange
Yeah.
them, but
But this is the one that he's been asking for, which is the reinforcement. Correct? And we
Yeah.
have size 7 French and 8 French. That should be in the drawer.
We can
Plus-
use those sometimes for access, like if you think you're gonna go on and wait
Oh, yeah.
for Dr.
Correct,
Wong to
right,
come in, we
so
need to access the
Not for
artery.
ECPR, but for patients, like for example, we're on standby for these high-risk OB cases, whatever. We'll put
Oh,
the
yeah.
wire reinforced catheters, and because those then, once they, we have access, they allow us to put wires up and dilate them up, put them on ECMO fairly quickly. But again, the wire reinforcement keeps us from kinking and losing access, because, you know, as you can imagine, when they're in delivery, they can be positioned in a number of ways. You wanna make sure that your catheters don't get kinked.
In my experience, the distal perfusion cannula, that comes like after we get
Yeah, it's
home.
at the end, it puts you on.
There's a lot of stuff
It's
we're
not a
talking about
rush.
today, so.
Right, it's not a rush.
Are we okay talking about rolls now?